There we go. Awesome. All right, guys. So as everyone's got their lunch or is grabbing their lunch or making their way back, uh, we don't need to be formal. Don't need to feel like you got to sit down or anything like that. I just wanted to say good morning, afternoon. I think it's still the morning, right? It's still good morning. I'm still John Prpich, still a peds pulmonologist down in Tampa, Florida, and the co-chair for the coalition. And I'm doing two talks today. So this talk is actually a branded talk. It's important to say that it's on behalf of AstraZeneca, who was so kind to help help to support this meeting and help pay for some of the sandwiches and things that you guys are eating. So I think it's a good thing, right? And although it's a branded talk, I don't want to, and so there's a focus, right? Like all branded talks, there's a focus, but it doesn't mean that there's not things I think that we can learn, and there's not ways that we can talk about asthma and talk about asthma management. And especially, I feel like our focus of this meeting today has been more around shared decision making and kind of patient interaction, and as always, patient education. And I completely agree with Dr. Ramirez earlier, who was sort of championing the need for us to be focusing on our patients that have mild persistent asthma, and that yet although this is a small number, the severe, sort of moderate and severe persistent asthmatics are a smaller number. It is still important, I think, to know some about the physiology of it. I think you've seen a couple of slides that usually get thrown up pretty quickly around some of that inflammatory cascade. You've heard some mention about the kind of hygiene hypothesis, and I think all of that is actually some of the really interesting things about asthma as we think about where does asthma start and how does asthma evolve and where does it come to be. And although it's very complicated and by no way do we have all the answers, it's these biologics, right? This new sort of world of medicines that have really been a big part of helping to open that up and help us to understand really what we call in vivo, in the patient, what impact this inflammatory cascade really has in these significant asthmatics. And so before the biologics were around, I mean, if you were to pull a pulmonologist and ask them about what's IL-5 and IL-4 and IL-13, and no one even knew about TSLP at the time, we would have looked at you like you were crazy. And now I think it's just part of our normal vernacular and our vocabulary. But it's because we have these biologics that help us impact this whole inflammatory cascade. And so we'll talk a little bit about that as we move forward. But really, like I said, focusing, and of course the focus on the biologics is around more that moderate to severe asthmatic when we're looking at treatment options. But like always, and I think this is important when we talked about AirQ and evaluation, the two, at least I feel like professionally, the two biggest challenges that we have in Florida, especially in taking care of pediatrics, is what do we call asthma? So the timely diagnosis of asthma, and then asthma assessment, right? So assessing whether or not that asthmatic is under control, and that's important, right? And so, we know, and you've seen, there's been lots of different versions of different slides that talk about asthma exacerbations and the number of asthmatics that are not under control. This is sort of a similar one, right? 8.5 million patients, in the past year that had an asthma exacerbation. It interrupts our quality of life. It impacts so much about what we do, right? 2.5 million patients in the US that would be qualified as having severe asthma. And so one of the things that we do sometimes with our asthmatics, I say, is we like to put them in buckets, right? So we like to put everyone in these certain sort of categories in terms of mild intermittent, moderate, severe asthma. So much of how we do that and why we do it is based on some of our historical thoughts around what medicines it takes to get them under control, which is becoming a lot more blurred. I think you even saw it in some of the slides when we were talking about asthma and pregnancy. You saw it even in Dr. Summer Ramirez's slides. We're expanding this thought, this way that we use some of our inhaled corticosteroids. We're expanding this thought, this way that we look and focus on inflammation. And I think part of it is because we recognize that even our mild intermittent, certainly our mild to moderate persistent asthmatics, the inflammation is there, and we've been underappreciating its presence, right? And so certainly in our moderate to severe asthmatics, that inflammation is there more significantly and often is more symptomatic, right? And so when we think about those symptomatic or those severe asthmatics, one of the other buckets, one of the other things when you saw that big inflammatory cascade are these patients that have what we call sort of eosinophilic asthma or TH2 or T2 high asthma, right? In that, I'm sure everyone took a mental snapshot and you can just recite that entire inflammatory cascade right now, right? If I just polled the room, but this basic idea, right, that within a significant number, especially in our moderate to severe asthmatics, there's this irritant, it's an allergen, it's whatever it is that's interacting at an epithelial surface in our airway. and sometimes our GI tract, sometimes in other, wherever we're coming in contact with the world, and then it triggers this cascade. And one of the things later on, I'm talking about shared decision making. One of the things that is, I think, important when we're talking with patients is educating them about how some of these medicines work. And I would say, as a class, these are the hardest medicines to try to explain to families, because honestly, sometimes it's a hard medicine to explain to other physicians, certainly, kind of medical students. It's very complicated. But one of the analogies that at least I've found has resonated is I use the analogy of a relay race, right? There's this idea that there's something that starts it off, and we can have all kinds of cool conversations about what does that mean and when does that happen in life or ongoing as you go through your life. But something starts off that cascade, and in certain patients, they're sort of skewed, they're more predisposed to have this inflammatory cascade that lends itself towards allergic or eosinophilic driven inflammation. And so the idea is that these triggers trigger cells that are sort of there to sense things, and then they release mediators that trigger other cells, that release mediators that trigger other cells. And those mediators are these interleukins, or these sort of cellular communication sort of signals, right? And what these biologics do on a whole is they go in and they take that baton, one of the batons, out of that relay race, right? So now the trick is sometimes as we're trying to decide which to use, what baton do you want to take out of that relay race? And there's an art to that for sure. And we're evolving and trying to figure out better ways to do that. But that idea that we're able to go in and take that one baton out of the relay race, it doesn't mean that the race stopped, but it means that a certain part of that race is not able to continue to go on. And families at least understand that, because you start saying interleukin 4, interleukin 5, interleukin 13, TSLP, you lose them. But it's this block, right? This eosinophilic asthma, this T2 high asthma. And when we see patients, we're all getting much more familiar with doing biomarkers, right? So we're always looking for the CBC. We're hoping that CBC was done before they got any steroids, so that you can see if there's any eosinophils present. So we define that as if the peripheral eosinophil count is over 150. And for those that aren't sort of used to looking at the CBC, remember you always have to move the decimal point. So for instance, greater than 150 on the CBC, it would be 0.15 if you looked at the absolute count, right? And if you're looking for over 300, it would be 0.3. But we find these severe asthmatics, and that EO count is 700, 800, very, very high. And so we try to do these biomarkers as we're trying to figure out, okay, which of those relay races do we think is the most important? What do we think is the strongest signal? Because we've got these tools to impact it. We know clinically that a lot of these patients have a lot of things in common, right? These tend to be our more symptomatic patients. They tend to already be on a lot of medicine, or at least we prescribe them a lot of medicine, right? They tend to be on either medium or high dose ICS LABA therapy. They're still having exacerbations, right? So they're still having, needing prednisone. They're still in the emergency room, and that and often they have a lot of nighttime symptoms, right? Inflammation is a message that we really preach in asthma, and we worry more about that nighttime inflammation, or at least symptoms at night, that's a big signal that there is inflammation that we don't have under control. We know there's a circadian rhythm to that inflammation, and so when they're waking up at night coughing, if they're waking up needing their rescue inhalers at nighttime, that's a big red flag and really makes our head whip around and start to ask them about frequency and when is that happening. But in this block, those are some of those sort of typical symptoms, and they're at more risk, right? I mean, all of our asthmatics, you heard before, all of our asthmatics are at risk. The biggest predictor for an asthma exacerbation is a previous asthma exacerbation. But the more severe kids are at more risk, and adults are more risk for more severe asthma exacerbations. This past winter, I named it was the winter of Asthmageddon, because we had more severe asthmatics in our PICU than I have seen in a very long time. And that's even before the lockdown and before, yes, things sort of slowed down. We've just had, it really was very significant in terms of just the acuity of what was coming into our hospital and what we were seeing in the PICU. It was just very, very scary, right? And so this is the population that we worry about: more fatal exacerbations, increased risk for exacerbations, need for the emergency room, and then of course the need for those corticosteroids, right? Our goal is to not need those corticosteroids at all. That's the reason. So in this sort of vignette, right, the sort of, how did she get control? And of course it was the use of this particular biologic, FASENRA, which is indicated for patients that are 12 and above. Of course, not used for acute management, and not really currently indicated for any other eosinophilic condition. And so the mechanism of action, right? So we talked about that relay race. And so the typical or sort of prototypical type 2 high cytokines that get released and really carry the signal are IL-4, IL-5, and IL-13. A little bit further down, up at the top surface, there may be TSLP, kind of also transmitting that signal. And so there's two products that can block that IL-5 interaction with the eosinophil, but the way FASENRA does it, which is pretty cool, is it binds to the receptor for IL-5, right? So it blocks to that receptor, and what it does is it actually targets the eosinophil for a really cool word called apoptosis, which means cell death, like a little assassination. So within 24 hours, that peripheral eosinophil count goes to 0. And thankfully, we don't really use our eosinophils for a lot of other stuff, right? I actually heard one speaker mention or sort of referred to the eosinophil as the cellular version of the appendix. And so unless you live in a high parasitic area where you're constantly having to fight off parasites, it's not a major population. So if you really feel like that's the big drive, if that's the main signal in your race, FASENRA is going to take that count to 0 within 24 hours. And so the trials that were kind of used to get it approved that sort of showed its efficacy, there was 2 exacerbation reduction studies and then 1 larger oral corticosteroid reduction study. And so this just sort of goes through the sort of enrollment and kind of study design. But really, I think one of the things that's important when you're looking at any of these studies is you want to ask yourself, so the patients that were enrolled in the study, do these sound like patients that I take care of, right? Is it a population that's applicable to me? And so in these studies, these were kids that were, or patients rather, 12 to 75 kids. But they were still having significant exacerbations, right? On average, they were having at least 3 exacerbations in the last year. They had low lung function, right? Their mean FEV1% predicted was 58%. I mean, that's a low FEV1 coming into this trial. And that's on, medium to high dose ICS/LABA therapy, plus minus even other medicines, like you heard mentioned, the long-acting muscarinic agonists, right? So like Spiriva or other inhalers, and they're still having exacerbations and they're still having low lung function, right? So that's I think that's important, when you're looking at, these are the worst of the worst, getting enrolled either to placebo or to receive FASENRA. And so Sirocco was 48 weeks, Kalima was 56 weeks, and then that oral corticosteroid reduction trial was 28 weeks, but then they were able to roll into dose extension trials, right? So the other thing is, okay, great, so you see that EO count go to 0. What happens after year 1, year 2, year 3, year 4, year 5? And so now that we've had these medicines out for a while, we're starting to get some of this really good long-term data to show that it still works, right? And so these dose extension trials really still show data out to 5 years. And so the study endpoints for the dose extension trials, we're looking at, of course, safety and tolerability, but then also looking at annual asthma exacerbation rates. And specifically in the slides, these were patients that were what we call high EO patients. So that absolute EO count is above 300. I think the take home is, if at least based on the blood work, this is a patient that you would think, man, that EO count, those eosinophils really seem like they're playing a significant role in what's going on in the patient. And so you can see over that 5-year period, you really see a very significant reduction in exacerbations. The initial trial for essentially that first year, you saw, especially in that high EO, population, reduction down to 76%, but it persists. It really keeps going and going and going. And by year 5, 90% of the patients had no asthma exacerbations. And once again, remember, these were patients that were having on average 3 exacerbations every single year. So pretty powerful impact on these patients. Here you can see it sort of listed out like by number, and one of the other ways to kind of think about these numbers is when you look at some of these decimal points, like for instance year 5, it took from 3.1, so 3 exacerbations in a year. Now you're down to like 1 exacerbation every 4 or 5 years. I mean, that's a huge, because when I look at decimal points, I'm like, I remember it's not as meaningful as when you lay it out. So what does that mean for that patient? Because remember, especially in pediatrics, when someone has a bad exacerbation, when someone ends up in the hospital, that means the mom or dad can't go to work. That means someone's staying home, they're missing school. I mean, the impact on the family is huge. And so when we're able to take these things really down to essentially 0 or really, really minimally, over the course of years, it's a huge impact to the family. And of course, adverse reactions across those 5 years, really, we saw no different than placebo. Really, probably the most common was drug site interaction or drug site injection reactions. But it's also good to see that there's no big safety signal that's been identified. The other, all the biologics are injection. We don't have anything that's by mouth yet. Everything is injection. They're all slightly different frequencies. The one nice thing about FASENRA is that there's a loading dose, 3 times a month for the first 3 months. Sorry, once a month for the first 3 months, and then after that, it's every other month. So in terms of the number of injections, it's the least frequent, which depending upon who you're talking to, if you're going to do either home injection or in the office, or if they drive far, or if they have a needle phobia, like my 16-year-old, being able to do the shot less frequent makes a really big deal. And so, I think it just looking at that sort of efficacy, looking at the consistency over time is really important, and doing that with the least frequent number of injections, I think, is important as well. And so, like all the biologics, so essentially the safety and sort of contraindications slides for all the biologics are almost essentially the same, especially if they're blocking IL-5 in interaction with the eosinophils or impact the eosinophil function or number in any demonstrable amount. There's always a caution if there's any risk of helminth infection, or if they have any helminth infection, you want to treat the helminth infection. If you're having a hard time getting that under control, you stop the medicine, treat it, and then you can restart it. Really, the only contraindication across the board for any of them is a hypersensitivity reaction. Thankfully, really have not seen that very often at all. And then, like any of the medicines, right? So by the time you get to this moderate to severe population of patients, very often they're either on courses of steroids frequently, or they're themselves maybe dependent on steroids. Thankfully, at least in our clinic, I can think on one hand the number of patients that I've had to be on steroids every other day or on a daily basis. It's a small number in pediatrics, but it's nothing to have a child come into my office, and when you start to go through the number of steroid bursts that they've been on, that they got some from the pediatrician, and they got some from urgent care, and they got some from the ER. And because this is, it was always a problem, but it's become an exponentially larger problem, as I don't know if you guys have noticed, but everywhere you look, there's hospital systems putting up freestanding ERs, freestanding urgent cares. They are everywhere. And none of those in general, depending upon who runs the system, but most of those are not connected to the EHR in the same way that a typical hospital system might be, or if it's the same hospital system over and over and over. So, and especially with COVID, everyone was worried about going to the emergency room. They somehow view these urgent cares as safer. So they're using these urgent cares, right, as their either primary care provider, or they're using these urgent cares just because they think it's going to be easier, cheaper, less copay. I don't know. But it's an epidemic of how many kids are going into these, either urgent cares or just freestanding emergency rooms. And they're getting this hodgepodge of oral steroids. And it amazes me often when these moms will come in or dads will come in, and I'll ask what meds the child is on, or when was the last time they were on steroids, and they don't know. They just know they went to the urgent care, they were given some medicines, and they don't know even what they were given. And a lot of times so one of the things that the emergency rooms will do very frequently too is they use dexamethasone as opposed to prednisone, right? So that dexamethasone dose may be one time. They just give it one time in the emergency room. They've got a pretty good literature base that give that one dose, and they do better than if they were to give them a 5-day course of oral steroids, because nobody takes their medicine ever. Sometimes there's better, like if they give one dose of dex and then they give them a script to fill one more script of dexamethasone, whether they fill that or not, but they don't even know that they got a systemic corticosteroid that's got a long half-life, right? It's in their system for days and days and days. So we don't have a handle on in this population of these symptomatic kids how often they're getting exposed to systemic steroids. It's a very hard thing to get an accurate handle on, and it's a problem just to even keep track of, right? I think one of the so actually one of the things that I did want to call out, so the talk on pregnancy and management of asthma was phenomenal. It's the thing I get the most scared about, right? So I'm a pediatric pulmonologist, but I do get patients that get pregnant. Usually it's unplanned, occasionally it's planned. So I'm able to actually have a conversation with them, but usually it's unplanned. So I'm left with this, young lady, and now she's pregnant, and we don't, as a practice, take care of pregnant patients with asthma because of just our kind of level of comfort. But it's hard to find providers that do, and so it's any education that we can do, I think is amazing. There is this amazing, so up there, that mother-to-baby.org, that registry is phenomenal. There's a lot of good resources, even just outside of biologics, just a lot of really good resources about different medications and what impact that might have. So it's a really good website for moms or to give moms if they are pregnant. Like anything, there's not, like he had said, there's not any double-blind sort of placebo-controlled trials, but there really is not currently any, with the data that we have, any literature to show an adverse event. So I appreciated his approach of, I think, you know, ABCs, right? Airway, breathing comes before everything else. So if the mom is not breathing, or if we're having a severe asthma exacerbation, it doesn't really matter. And so the summary, it really isn't that many slides, which I appreciate because I tend to talk kind of fast. But I think, so within that, like I said, focused on FASENRA, but just sort of this broader idea of inflammation and the broader idea of type 2 high, sort of T2 high, eosinophilic asthma. Was there any questions that I might be able to answer? Silence. Yes.
How do you overcome the nervousness or hesitation in your patients to start a biologic? How much fear is there because it's injected?
Right. So, I mean, I think, like anything, part of addressing someone's fear is you've got to get them to define what they're afraid of, right? And so that's what I'm going to talk about later as we talk about medication compliance or, you know, shared decision making, is having that conversation about what their level of understanding. Are they scared about the medicine itself? Are they scared about the mechanism? Are they scared about the shot? Are they scared about coming to my office every month, which sometimes I'm scared of? Because that's, I mean, if you don't know what their fear of, then you don't have a way to start, right? So understandably, a lot of the fear is around just what are these medicines doing? And since it's given as a shot, it gets a lot of sort of cross fear from immunizations and everything that we've gone through and all of that kind of stuff. So the first thing I start off is, this is not a vaccine, right? Because that just, it's in their head because it's a shot. I mean, we ran into this with Synagis, right? With, you know, any of our monoclonals that we've been around for a very long time. If it's given a shot, people think it's a vaccine. But then, you know, trying to talk through that mechanism, right? And using that analogy. And then the other analogy I'll use is, I was like, you know, so if you had to compare, I'm able to go in almost like a surgical scalpel, really take out this one specific part of an inflammatory pathway, as opposed to a nuclear bomb, which is steroids. It does not discriminate. These steroids come in and they have broad side effects, right? They have broad impact on the patient. And usually by that point, if we're talking about biologics, one, the kids are symptomatic frequently. So usually the family's already invested in understanding that their kid has asthma and their asthma is not controlled, and there's, you know, and there's something about that. But then they also usually have seen steroids frequently, and they have at least hopefully a little bit of a fear of steroids. So kind of jumping onto that fear of steroids, talking about that, which would you rather, this nuclear bomb of a medicine that's, you know, being given to your child on a regular basis, versus being able to at least go in a very specific way with a really much better side effect profile. And really address the inflammation. And then sometimes I'll talk about just the life-changing, you know, kind of stories, right? The patients that I used to see get intubated. I mean, really, really severe. And we get them on a biologic and they're not, I mean, they do phenomenal, right? Just the impact of quality of life in this population of asthma has just been life-changing. Yes?
John, I wanted to reiterate great talk.
Yeah.
We're dealing with a cohort of patients that is a small subset. As I mentioned, the vast majority of patients are in the mild to moderate category and risk for exacerbations and mortality. So this group of patients now, it's an amazing opportunity to intervene when appropriate. And advanced in terms of the fear factor, I think that these are patients that have been intubated. I think any kid that's been in the ICU needs to be flagged for a biologic. And whether it's one intubation is one intubation too many. So these are patients that, in my mind, are the red flag, and you'd be surprised how often that they're missed. I think large hospital systems are certainly capable of monitoring kids that are in and out of the emergency room, alert the emergency room staff, especially that child may not be adherent. So rather than jump into a biologic, or push I call the biologic button, check for adherence and proper airway delivery systems, whether you're using DPIs versus HMAs, or you're using spacers. All of these things make a big difference in terms of the ultimate control. And of course, in using the right type of metric system.
Right.
And I think that AirQ versus, again, there'll be the AirQ for children coming up soon. But again, as you say, that this is a small cohort of patients. Behind every adult with severe asthma, there once was a child probably with asthma that was missed.
Yep.
And again, this simply begins early on as a peak pulmonologist. You take care of the future of patients like this. And again, great talk.
It is. I mean, it's super interesting, and the story is still unfolding. But that skewing towards this type of what we call kind of phenotype, or this skewing of this type of these mechanisms, right, really, it seems like very likely happens very early in life. And that back, they'd mentioned some of the hygiene hypothesis and some of the exposure stuff. I mean, there really is some very interesting stuff. I mean, early in life, meaning what happens prenatally, what happens in the womb, what happens. I mean, it really is just, I think, such an interesting story. But also, and I'm getting flashed. My eyes are old. I can't read that far back.
3 minutes.
3 minutes. Okay, so man, 3 minutes. I can get a lot in 3 minutes. No, but Dr. Ramirez, right? Don't get me wrong, and I think it's exciting to have this next option, right? It's exciting to have this next step, and I mention it to families because I don't want it to all be doom and gloom. But before you get to that conversation about biologics, you better hope that number one, you've got the right diagnosis, and that sometimes is challenging, right? We have a lot, or not a lot, but there's a subset of kids that have airway anomalies, they've got tracheomalacia, the history of vascular. I mean, there's all kinds of things that be a reason for them to be coughing, for them to be short of breath. I mean, there's lots of other reasons. But so you better make sure you got your diagnosis right, and then compliance, and it's not perfect. Don't get me wrong. I mean, you can sometimes. I've had grandma sit in front of me and say, "Look, I cannot get Jimmy to take his Symbicort to save my life. It does not matter. So if I can bring him to your office and you can give him a shot, I'm going to do that." And I'm not saying that we don't do that at times, but it's when we've exhausted at least our best attempts to get them to be compliant with the appropriate medication. And so, that is so key, right? And drug technique, how they're doing it. Half the time when I see a new patient, I don't change what I'm doing. I just teach them how to do their inhalers, right? I mean, show appropriate technique is huge, 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 huge. But it is exciting to know that when you go through all those steps appropriately and you get to this point, we have some really, kind of amazing options that are exciting. And as we even get new options, what it does is it also starts to begin to give us more information about what's happening under the hood, right? The more biologics that come into the market, the more information, like I said, in vivo, we get to these mechanisms. And so that's why it's just been so exciting to watch our knowledge and just explode in terms of what's sort of happening with these kids. And so it's a really exciting time, I think, to take care of asthmatics. Yes.
So you may have said this, but at what point do you prescribe a biologic over
Sure. So typically we think when we start getting into that sort of great, step 4 or 5 therapy, right? So as you go that stepwise management pattern, right? So you've made your diagnosis, you assess sort of what, kind of the severity, you start them on medication, and then it's that cycle that you see in GINA, the cycle you see in NHLBI, that then you bring them back to clinic and you reassess. Are they controlled or are they not controlled? And you reassess and you reassess, and are they still having symptoms? And so as you climb that ladder, these are really indicated for those patients that are still symptomatic, still having asthma exacerbation, still needing steroids, still needing the emergency room, still having impact. And that's in spite good compliance as best you can assess with either medium to high dose ICS LABA therapy. So so I'm in private practice. I don't work for a university, so I can say brand names. So Advair, Symbicort, Dulera. They often have Spiriva, or one of the long-acting muscarinic agonists, added on top of that, and they're still symptomatic, right? And so still symptomatic in spite of that, at least your best attempt at compliance, that's when you think about a biologic.
That was
Not bad for 30 minutes.